Welcome to our second and last video on environmental toxicities. Let's begin. In this lecture, we'll discuss methanol poisoning and ethylene glycol poisoning. For each of these topics, we'll discuss the definition, pathophysiology, etiologies, clinical presentation, diagnosis, and management. Let's begin by talking about methanol poisoning. Methanol poisoning occurs when someone ingests excessive amounts of an alcohol called methanol. First, let's go over some important pathophysiology. Methanol, in its ingested form, is not toxic. However, once metabolized, the metabolites of methanol are very toxic and they lead to symptoms of methanol poisoning. Methanol is metabolized by the same enzymes that metabolize ethanol. These two enzymes are alcohol dehydrogenase and aldehyde dehydrogenase. Let's take a moment to draw the pathway of methanol metabolism. Methanol is first converted to formaldehyde using the enzyme alcohol dehydrogenase, and then to form acid using the enzyme aldehyde dehydrogenase. Formic acid is the most toxic metabolite and causes the majority of the damage in methanol poisoning. Methanol is metabolized to formic acid. The formation of formic acid causes a high anion gap metabolic acidosis. It's high yield to know that methanol is found in home brewed alcohol. Other sources of methanol include antifreeze and windshield wiper fluid. The typical presentation of methanol poisoning consists of an anion gap metabolic acidosis and vision disturbances such as blurry vision, a central scotoma, or blindness. The methanol metabolites, especially formic acid, are very toxic to the eyes, causing all these eye-specific symptoms. Here we can see that a central scotoma is essentially a blind spot in the center of the visual field. Remember that the toxic metabolites of methanol poisoning can impact the eyes, leading to a central scotoma. Diagnosing methanol poisoning is typically based on the history as well as the clinical signs and symptoms. Clinicians can measure serum methanol levels to confirm the diagnosis. However, this test is not widely available. Additionally, an elevated plasma osmolol gap can help support the diagnosis. Let's discuss the osmolol gap in a little more detail. The osmolol gap is the difference between the measured plasma osmolality and the calculated plasma osmolality. A normal osmolol gap is less than 10. The measured plasma osmolality is measured in the laboratory. The calculated plasma osmolality can be calculated using an equation. This equation is worth committing to memory. Calculating plasma osmolality is equal to 2 times the plasma sodium plus glucose divided by 18 plus BUN divided by 2.8. By this equation, we can see that 3 things contribute to plasma osmolality are sodium, glucose, and urea. If there is a difference between the measured plasma osmolality and calculated plasma osmolality that is greater than 10, it means that there is some other osmol contributing to the plasma osmolality that is not sodium, glucose, or urea. If the osmol gap is elevated, this narrows the differential diagnosis of the high anion gap metabolic acidosis to a few possibilities. The most common reason to have an elevated osmolar gap is ethanol poisoning, but this can easily be ruled out with a blood alcohol level. 2 other common causes of an elevated osmolar gap include methanol poisoning and ethylene glycol poisoning. Other alcohols can also cause an elevated osmolar gap, but these are not as high yield. To determine which substance is the cause, the clinician should consider the patient's history and symptoms. Each of these types of alcohols will cause a unique set of findings that we will discuss in further detail later in this lecture. To illustrate this, let's imagine that the lab tells us they measure the patient's plasma osmolality and they found it to be 300 milliosmoles per kilogram. But then we decide to calculate the plasma osmolality by factoring in the patient's sodium, glucose, and BUN. And let's suppose that according to our calculation, the patient's serum osmolality should be 250. That means that there are 50 milliosmoles per kilogram that are not being accounted for in the equation. So where are those 50 coming from? They are osmoles that the lab can measure, but that we cannot calculate because they don't factor into the equation. These osmoles are likely coming from alcohol. The first steps in management of methanol poisoning are supportive treatment, including possibly mechanical ventilation and IV fluids. If mechanical ventilation is required, it may be necessary to set the ventilator to a large minute ventilation to attempt to correct the acidemia. By increasing the ventilation, the patient blows off CO2, causing respiratory alkalosis. This respiratory alkalosis will oppose the high anion gap metabolic acidosis that is being caused by the formic acid. Methanol poisoning can be treated by administering one of 2 medications, fomepizole or ethanol. Fomepizole is the usual treatment of choice, and it works by inhibiting the enzyme alcohol dehydrogenase, which is the enzyme that converts methanol to its toxic metabolites. If fomepizole is not available for treatment, ethanol is a second-line agent that can be used. Since ethanol is normally metabolized by alcohol dehydrogenase, administering ethanol will cause it to act as a competitive inhibitor of alcohol dehydrogenase. This results in less methanol being metabolized by alcohol dehydrogenase because many of the active sites of the enzyme are already being occupied by metabolizing ethanol. Here is the pathway that we drew earlier depicting methanol metabolism. Remember that it is the metabolites of methanol, not methanol itself, that are toxic. Fomepizole and ethanol function by inhibiting alcohol dehydrogenase. This prevents the formation of toxic metabolites. A 3-year-old girl is brought to the emergency department by her parents after accidentally ingesting antifreeze. The basic metabolic panel reveals sodium of 139, BUN of 14, and glucose of 90. The measured plasma osmolality is 308. Calculate the osmolar gap in this patient. This 3-year-old girl has accidentally ingested antifreeze, which contains ethylene glycol. Ethylene glycol is a toxic alcohol, the metabolites of which raise the plasma osmolality and result in osmolar gap. Here we need to calculate the osmolar gap in the patient. Osmolar gap is calculated as the difference between the measured and calculated values of plasma osmolality. The measured plasma osmolality is 308. Now we need to calculate the plasma osmolality based on serum sodium, bicarbonate, and BUN levels. The formula for osmolality is the following: 2 times the sodium plus BUN divided by 2.8 plus glucose over 18. If we plug the numbers in this formula, we receive the osmolality of 288. Therefore, the osmolar gap in this case is 308. This gives us the osmolar gap of 20. Let's move on to discuss a topic that is very similar to methanol poisoning, ethylene glycol poisoning. Ethylene glycol poisoning occurs when someone ingests the chemical ethylene glycol. Similar to methanol, ethylene glycol is not toxic in its ingested form. However, once ethylene glycol is ingested, it becomes converted to toxic metabolites. Ethylene glycol is metabolized by the same enzymes as ethanol and methanol. Again, these enzymes are alcohol dehydrogenase and aldehyde dehydrogenase. The 2 toxic metabolites of ethylene glycol are glycolate and oxalate. Glycolate and oxalate are responsible for causing the damaging effects of ethylene glycol poisoning. Since they are both acidic, they will also cause a high anion gap metabolic acidosis. Additionally, oxalate naturally binds to calcium in the body, which leads to characteristic findings that we discuss in the later slides. Here we illustrate the metabolism of ethylene glycol. Ethylene glycol is first metabolized by the enzyme alcohol dehydrogenase. After several steps, it is converted into the metabolites glycolate and oxalate. Again, these 2 metabolites are responsible for the toxic effects of ethylene glycol as well as the acidosis. 2 common sources of ethylene glycol include antifreeze and windshield wiper fluid. Because these 2 fluids are commonly stored in the garage, this poisoning may present as someone who was found in their garage unresponsive on the floor next to a bunch of open containers. The very high yield fact to remember about ethylene glycol poisoning is that the metabolites are toxic to the kidneys, which can cause acute renal failure. Since oxalate binds to calcium in the body, this can lead to the formation of calcium oxalate kidney stones, which may cause the patient to present with flank pain, hematuria, and oliguria. This is in contrast to methanol poisoning, which, if you remember, is very toxic to the eyes. When oxalate binds to calcium, it can also cause hypocalcemia, which leads to a couple of manifestations that are important to keep in mind. First, hypocalcemia causes QTc prolongation on EKG, which can progress to cause cardiac arrhythmias such as torsades de pointes. Another common consequence of hypocalcemia is muscle twitching, which may also be seen. Here's a picture of what calcium oxalate crystals look like under a microscope. One easy way to remember that these are calcium oxalate crystals is by thinking of the X in the word oxalate. If one takes a look at each one of these crystals, one can see a little X inside each one. These crystals are also described as having an envelope, because the X in the middle of them looks like the folds of the back of an envelope. A 47-year-old woman is brought to the emergency department due to vomiting and severe right flank pain radiating to the groin. She's an alcoholic and she drank antifreeze when she ran out of alcohol. Her laboratory studies are significant for high anion gap metabolic acidosis. Urinalysis shows envelope-shaped crystals. The patient is diagnosed with nephrolithiasis. What is the most likely pathophysiology for nephrolithiasis in this patient? This patient drank antifreeze. Antifreeze contains ethylene glycol. Ethylene glycol is converted into glycolate and oxalate in the body. These acids result in a high anion gap metabolic acidosis. Additionally, oxalate combines with calcium in the urine, forming the envelope-shaped calcium oxalate crystals. Calcium oxalate crystals then form the kidney stone. This is why a patient with ethylene glycol poisoning is predisposed to nephrolithiasis. Ethylene glycol poisoning is a clinical diagnosis, meaning the diagnosis can be made based on the patient history together with clinical signs and symptoms. As with methanol poisoning, there is a test that can measure serum ethylene glycol levels. However, this test is not widely available. Additionally, ethylene glycol poisoning can cause an elevated osmolar gap. The treatment for ethylene glycol poisoning is the same as methanol poisoning. Fomepizole is the treatment of choice. Ethanol is an alternative if fomepizole is not available. A 37-year-old alcoholic patient is brought to the emergency department due to vomiting and confusion for the past 6 hours. Basic metabolic panel shows sodium of 136, potassium of 3.4, chlorine of 100, bicarbonate of 14, OSM of 285, BUN of 30, creatinine of 1.5, glucose 105, pH 7.29, partial pressure of CO2 of 7, and partial pressure of O2 is 90. The patient complains of blurred vision. Methanol poisoning is suspected and fomepizole is administered. What is the mechanism of action of fomepizole? This alcoholic patient presents with vomiting, confusion, and blurred vision. His basic metabolic panel is significant for acute kidney injury, evidenced by a high BUN and creatinine, and metabolic acidosis, evidenced by low bicarbonate, low pH, and low PCO2. Therefore, this patient has the metabolic acidosis along with blurred vision. These are the classic features of methanol poisoning for which fomepizole is administered. Fomepizole inhibits the alcohol dehydrogenase and prevents conversion of methanol into formaldehyde and formic acid. Formic acid is the most toxic metabolite responsible for the optic nerve injury. Here's a summary slide containing many of the high-yield facts about each of the 4 types of poisonings that we've discussed in this lecture and previous lecture. Let's conclude this lecture with a board-style question. A 27-year-old man is brought to the emergency department due to severe flank pain radiating to the groin for the past hour. He has a past medical history of poorly controlled major depressive disorder. 5 hours ago, he drank antifreeze in an attempt to end his life. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 130/80, heart rate of 89, and respiratory rate of 22. Physical exam reveals pain along the left flank, which radiates to the left groin. Costovertebral angle tenderness is absent. Arterial blood gases reveal pH of 7.2, bicarbonate of 15, and PaCO2 of 25. The basic metabolic panel shows BUN of 15 and creatinine of 1. Urine microscopy reveals dumbbell-shaped crystals. Which of the following is the best treatment option for this patient? A. Ethanol, B. Fomepizole, C. Sodium bicarbonate, or D. Dialysis. This patient presents with severe flank pain radiating to the groin for the past hour. He has a past medical history of poorly controlled major depressive disorder. 5 hours ago, he drank antifreeze in an attempt to end his life. The antifreeze contains ethylene glycol, so he is most likely suffering from ethylene glycol poisoning. Ethylene glycol is metabolized into glycolic acid and oxalic acid, causing metabolic acidosis. This patient's arterial blood gases reveal low pH of 7.2, low bicarbonate of 15, and low partial pressure of carbon dioxide of 25. These values are consistent with the compensated metabolic acidosis. Ethylene glycol poisoning is further confirmed by the presence of dumbbell-shaped calcium oxalate crystals on the urine microscopy. This is because oxalic acid produced by metabolism of ethylene glycol combines with calcium, leading to calcium oxalate crystals. The best treatment option for the patient with ethylene glycol poisoning is fomepizole. Fomepizole inhibits alcohol dehydrogenase, decreasing the production of glycolic acid and oxalic acid. Therefore, the correct answer is option B. Again, here's the table summarizing methanol and ethylene glycol poisoning. Pause the video and take a moment to consider this table once more. Let's discuss why other options are incorrect. Option A is incorrect because although ethanol can also inhibit alcohol dehydrogenase and decrease the toxic effects of ethylene glycol, it is only used if fomepizole is unavailable. Option C is incorrect because although this patient has acidemia with a pH of 7.2, sodium bicarbonate is usually not administered unless the pH is less than 6.9. Finally, the option D is incorrect because although ethylene glycol causes nephrolithiasis and metabolic acidosis, dialysis is not indicated unless acidosis is severe or there are signs of acute kidney injury. This patient has compensated metabolic acidosis and his BUN and creatinine are normal, suggesting intact kidney function. And that concludes our lecture on methanol and ethylene glycol poisoning.